Hello and welcome to the Geeky Medics podcast. First off, thank you, however you got here, for stumbling upon us, a new monthly supplement for your podcast listening schedule. My name is Josh Chambers, a medical student at the University of East Anglia. This podcast, selfishly, gives me an excellent excuse to interview interesting doctors and healthcare professionals from a range of backgrounds, drilling down to why they chose the speciality they're in and what it's really like to do the job. In this episode, we're concentrating on global health, and we have someone with a really interesting story to talk to. Our guest in this episode is Dr Abdulkarim Ekzayez. In 2013, Karim was training to be a neurosurgeon when his residency was interrupted by war. He joined Save the Children in North-West Syria, where he led the health response until 2017. Helping build the primary healthcare system and restarting routine vaccinations. He is now working towards his PhD in Health Systems in Conflict at King's College London. Karim, thank you very much for joining us on the podcast.
Well, thank you very much for the invitation.
I've been doing some reading about you over the last couple of days, and you're an incredibly interesting person. I think we'll start right at the beginning, if that's okay. And you went to medical school in Aleppo in 2004. Could you tell us a bit about that?
Okay, so let's start from the very beginning. Why I choose medical career. So in the system in Syria, the education system, that after the high school you have kind of to select your university based on the marks or the grades or the final year in the high school. So in the final year of the high school, I was ranked as the second on the whole country. So it was kind of some pressure from my family and people around me that we should go for a medical school, because usually medicine in Syria is kind of on the top level of universities, the courses that you can choose from. So I went to this was not the only reason actually, but the reason was that I wanted to help people. So usually I enjoy helping people, especially in after accidents or these sort of things. So I went to the medical school in Aleppo, but unfortunately the medical school itself was not very kind of exciting for me, I would say. And to be honest, I did not enjoy it that much. So when I finished the medical school, I thought I should go to do surgery, because surgery, it's very much exciting and you can help people, and I love being in theaters to do operations. Yeah. So in 2009 I started kind of a surgical career. So I went to general surgery training, and then I went to neurosurgery training program, which in Syria it's 6 years training program. So I've done this in Aleppo, and in 2012, because of the conflict, Aleppo city was split between government forces and oppositions. And as a medical doctor, I was trying to help people from, regardless of their political affiliation. Mm-hmm. And in the governmental hospital where I was doing my medical training program, it was very difficult to provide your help regardless of political affiliations, because we've been pushed a little bit by, security agencies and different other agencies to sometimes to not treat protesters properly. Right. And this was very annoying for me, because, the motivations for me behind choosing a medical career was to help people. So I was trying to move between both sides of the city, between the governmental controlled ones and the opposition controlled ones. But at some point, it was not possible for me to continue like this, because both sides will question your presence at the other side. So I had to decide where to go. and I decided to go to serve people who are more needy. And especially in our post-health areas, there were only few doctors left serving large number of population. So in the eastern part of Aleppo, there were around like 1 million population or even more. And we were only like, I would say less than 10 doctors, especially surgeons, trying to, provide surgical help to people who suffer the most, because most airstrikes and, conflicts, incidents were happening in that part of the city. But then again, I changed my career path, and I would say in 2013, it was the point where I decided that I will change my career from surgery to more kind of public health stuff.
Sure.
And the reason behind this change was that I found there is more need to strengthen the health system in Syria, especially in the conflict-affected areas, and to respond to the public health threats, even much more than the need for surgery and trauma services. Because, doctors in Syria were trained to provide clinical medicine services, but they were not trained to provide public health services. And it was a weakness in the health system in general. So that's when I decided to shift to public health. So I don't know if you have questions about this period before I continue.
Yeah, sure. I think, that's a good idea. I wondered, you talked obviously about sort of training in surgery initially, and then moving into public health. But what was it like when the conflict started? How did the healthcare change? What was it like being a doctor? I mean, I've sort of read articles that you've written, and other things suggesting, in 2016 there was 800 medical workers were killed in Syria. So, what was it like working on the front line in field hospitals and knowing that perhaps, there is a risk of you being there?
Yeah. So, when the conflict started in 2011, so it started with only demonstrations and peaceful demonstrations in Syria. So our role as medical doctors was to receive people who injured during demonstrations, and usually kind of peaceful people, usually in 2011. So it was kind of straightforward work for us, because the casualties were kind of manageable scale. But in 2012, when armed conflict started, it was really a disaster, because the health system in Syria was not prepared to respond to massive scale conflict. So in like example, in Aleppo, the public surgical hospitals were only 3 major hospitals, and I was working in one of these hospitals. And in July 2012, we were flooded by like unprecedented number of injuries. Before the conflict, it was only rarely to receive like kind of shots in the head or, these sort of injuries. But starting from July 2012, it was on daily basis. We receive, I would say, tens or even hundreds of traumas that are related to, airstrikes, shots and clashes. And as a neurosurgeon, I must be in the ER or in the ICU or in the theater at the same time. But the problem, when the opposition forces, they entered the city, there was kind of some road closures, I would say. So doctors, who live outside of the city, they were not able to come to the hospital. And we ended up doctors who were in the hospital, we ended up covering shifts for all other doctors.
Sure.
So in July and August 2012, I had to stay in the hospital for 27 days a month. And 27 days means 24-hour shifts for 27 days, which is something impossible.
Yeah.
You know, and in the first week, I was kind of okay trying to provide the best that I can. But then next week, it really collapsed. So I was not able to provide the same quality of service that I would normally provide. And after a month of serving, like doing at least 3-4 surgeries a day, and with a lot of ER and ICU work. After this month, I had 2 disc herniations in my lower back, and I really collapsed. So I was not able to do anymore. Sure. But when I shifted to shift hospitals, the situation was much worse, because the problem was not only being overloaded by a lot of patients and injuries, but the problem was safety, because we were not able to work in a safe place. So I was responsible to do surgeries in field hospitals in a basement under a mosque, and even this mosque was hit many times, and we had to shift locations many times. So we had to cope first with trying to be on the move, and in the same time to cope with limited number of resources, mainly surgical instruments and equipment. Sometimes I had to do neurosurgeries using instruments for general surgery, which is really impossible in normal situations. But we had to cope with this. Sometimes I had to do orthopedic surgeries even without general anesthesia. Imagine if you would do external fixing for legs without general anesthesia. It was really impossible. So these sort of conditions that we had to cope with, considering the limited resources and the dangerous and risky environment around us.
So, I mean, despite obviously a great need for surgeons and neurosurgeons in field hospitals there, you obviously recognise the need for a public health response as well. So, could you tell us a bit more about how your role changed and how you saw the role of medicine changing in Syria at that time?
Absolutely. So, I remember the minute I kind of had this spark in my mind to shift to public health. This was in 2013, I think in October 2013, when a friend of mine, he is a doctor, he called me and explaining a case that he received, a 4-year-old boy with unexplained paralysis, and he thought that it might be polio, but in the medical school we have never seen any polio, because polio, in Syria was eradicated, I think in 90 or something. Yeah. So we've never seen a case. So it was really difficult to diagnose polio. But we've been hearing that because of the low coverage of vaccination, and because of the other conditions related to sanitation and crowded camps, that measles and polio might come back again. So when my friend called me and he was explaining the symptoms, I was trying to search some references, and yes, it is polio. So both of us, we were not able to do anything for this kid, because polio is untreatable. So and there are no kind of specialized centers to deal with these cases. So we try to refer the kid to Turkey, but we identify that if it's really polio, then what we're going to do, if it's untreatable, then we should focus on prevention. Preventions mean vaccination. Vaccination, in light of the collapsed health system, it's kind of an impossible thing to do. So I tried to contact with some people and some local doctors in the region, and all of us, we identified the need of resuming vaccination after the withdrawal of the Ministry of Health, the Damascus Ministry of Health. And with support from some local NGOs and international NGOs, we were able to do some vaccination activities, low-scale ones, before the polio outbreak was announced in October 2013. So when the polio outbreak was announced, all international organizations, including WHO and UNICEF, they came on board. And at that time, I started to work with Save the Children. And Save the Children, they had very much focus on vaccination in conflict-affected areas and preventions in primary healthcare in general. So I try to lead the Save the Children response for polio in coordination with WHO and UNICEF and all other actors. And in January 2014, we were able to start the first mass vaccination campaign to vaccinate each single child door to door in the conflict-affected areas. And the polio vaccination campaign has really changed my thinking, the way I think about public health interventions, because the campaign in less than a year was able to eradicate the polio again from Syria. After in 2013, starting from with 2013, there were around 36 confirmed cases of polio. In 2014, thanks to the campaign, there were only 1 or 2 confirmed cases. And in 2015, polio was almost eradicated. And there was another outbreak in 2017, I think, in the eastern provinces, in ISIS-controlled areas, but not in the opposition-controlled areas where the vaccination was taking place. So these sort of interventions changed my mind about the way that public health interventions can help and can strengthen the health system and can prevent threats that could be even impossible to tackle when it happened.
And it's probably quite easy to get swept up in the traumatic injuries in these conflict zones. But of course, people still get ordinary things. They still get diabetes. There is still antimicrobial resistance. There's still a need for tertiary care centres to treat cancers. Was this a key objective within your time in Syria?
Absolutely. As you explained, like working as a surgeon in field hospital, yes, you might be able to help one patient or like number of patients that you treat every day. But then the minute you try to refer a patient to another level of care, you identify that if there is no strong health system backing you, then you will not be able to do your job properly. So say, for example, when we receive cancer cases, there was no one single cancer treatment center in the whole opposition-controlled areas in Syria, or kind of like diseases like thalassemia or any other conditions, or TB, or especially AMR with for TB cases is kind of like a nightmare that you would not be able to deal with unless you have a very strong health system backing you. So these sort of challenges pushed us to think about like kind of comprehensive solutions that require strengthening the health system. Without strengthening the health system and trying to fill the gaps in each level of the care, starting with primary healthcare, secondary care, tertiary, and specialized care and specialized centers, you would not be able to help these communities. So yes, part of my focus was to try to strengthen the health system, considering the limited resources, which is really like a very difficult thing to do in conflict-affected areas, where you have limited resources, which most of the times go to trauma, because donors and organizations most of the time they see only the trauma problem, while all other problems, the long-term ones, including the communicable diseases, the interruption of non-communicable diseases treatment, the lack of specialized services, all these problems are kind of rarely recognized by international organizations and other actors. And even if they do recognize these problems, international organizations tend to focus on the problems that they can deal with more easily. And that's why most international organizations, they focus on trauma, and they located themselves next to the Turkish border, where they have more access than other places.
Actually, that leads me on to another question I was going to ask. about the ethical challenges of humanitarian responses. It's, you hear of charities sort of putting in money, like you say, that perhaps if put into other areas like communicable diseases, vaccinations, could save a lot more lives. So what have you seen that has been perhaps, I don't know, unethical in a humanitarian response, and how can we change this in future crises?
The problem that there is no ethical framework to deal with health interventions in conflict-affected areas and in humanitarian crises in general, because people expect from international organizations working in close to front lines to do whatever they can do, because it's not an ideal situation, so we cannot ask them to do more than they can do. But most ethical considerations focus on the way these international organizations deal or treat beneficiaries or patients. They do not focus on the way they allocate resources, which is really a problem, because as you said, if I invested in like a certain type of services and I put all my resources in this service, while I can do like much larger impact if I invested these resources in either a different place or a different type of service, then I think it is unethical to put all my resources in one place without thinking of where I invest my resources. And I think part of the solution could be to involve more kind of local actors in the planning, because yes, we need international experts to plan and design, but in the same time we need kind of equal partnerships between international and local actors to design health services and then allocate health resources properly to best invest the limited resources.
And this seems to link to the topic that you're currently researching in your PhD, which is the bottom-up approach to healthcare provision. Could you tell us a bit more about that?
Absolutely. So, considering all these challenges and the throughout the experience that I had in the responding to the Syrian conflict, I identified that there are a lot of gaps in our knowledge about health interventions in conflict-affected areas, especially when it comes to health systems approach to health interventions in conflict-affected areas. So that's why I said, okay, yes, I've got some practical experience in the field, but I need to have some academic experience as well to try first to enrich my knowledge about these interventions, but in the same time to try to fill gaps in knowledge in general. So I've done my master in epidemiology in London School of Hygiene and Tropical Medicine in 2016 and 2017, and I've chosen the epidemiology course because it's kind of a technical skill that allow you to understand the distribution of diseases and how to respond to tackle these diseases on community level, not on patients level. But after the epidemiology course, I identified the need to understand more the health security threats. So I've done a fellowship last year and with Chatham House with the Global Health Security Unit at Chatham House. I was focusing on protection of healthcare and AMR, NCDs and other issues. And that led me to my PhD now at King's College London, which I try to like kind of summarize all these issues in my PhD thesis, which is trying to look at how health system could respond to different health threats in conflict-affected areas, and how health interventions should aim to strengthen health system in conflict-affected areas. So I'm trying in my PhD, I'm trying to provide an example of a hybrid health system that was in the opposition-controlled areas in Syria that tried to make a balance between different types of health needs and investing the different sources that were available, the different resources that were available. So, and I will try to compare this to other contexts, including mainly around the Middle East, like including Libya or Yemen or even Afghanistan. Afghanistan is a bit of kind of post-conflict slash ongoing conflict, while all other areas, Syria, Yemen, and Libya, they are kind of prolonged and chronic conflicts. And the reason I'm interested in this health system approach is that in concurrent conflicts, we deal usually with chronic conflicts and prolonged conflicts. So there is no way that we can use only kind of acute health interventions that were designed to respond to maybe acute health needs for several months or maybe 1-2 years. We cannot use the same interventions for conflicts like the Syrian conflict that were going on for more than 8-9 years. So we think that the only solution is to have a health system approach to transform the type of health interventions we provide to aim to strengthen health systems and to have more sustainability after the acute phase of conflict ends.
Medical students and junior doctors are quite often interested in humanitarian response as MSF Society and things like that. What advice would you give to people interested in pursuing a career in global health? What sort of experience is required?
I think it's good to have practical experience, definitely. So I encourage them, yes, to work with international organizations like MSF, Save the Children, Oxfam, IMC, and ICRC. But maybe it would be good to have some internships first as junior doctors, to have some internships before going kind of on missions. It's good to have some like short internships, 1-3 months, to understand how these charities work, because I would say different charities, they work in different ways, and depends on what you would like to pursue in the future in terms of career path or even your kind of personal motivations. I think the type of charity you choose would differ. So if you are very much interested in kind of trauma services or care in Frontlines, then yes, definitely it's MSF, because MSF, they are known to be kind of first responders in Frontlines. But if you are interested in more kind of public health approach and health system approach, then maybe MSF would not be the right place for you to go. So yes, maybe an internship for 1-3 months would help you to identify how the charities work and how your personal goals fit their way of working.
I'm going to ask you one final question, if that's okay, perhaps a more personal one. I wondered if there was a patient you have seen or an experience you've had in your time working in these areas that has sort of changed your outlook on medicine, or you've talked of course of public health, but has, I don't know, stuck in your mind more than any other?
Yeah, I remember a lot of moments where they left a lot of impacts in the way I think I approach health interventions in these areas. So one moment when I was working in a governmental hospital in Aleppo, and I was working as a resident neurosurgeon. So I received twins around like 13th or 14th years old, and one of them had died already, and because of airstrikes, while the family were trying to save the brother. So they were begging that if we can help. And the problem, because we were overloaded, the type of surgery that we need to provide to this boy require an ICU care afterwards, and we did not have any places in the ICU unit at that time. So I tried to refer them But I knew that if I referred this boy, they will never be able to find any other place in the whole city. So I've taken the decision that I would take this boy and I will do the surgery, and then maybe we will do manual ventilation, because we don't have places in the ICU. So we will do manual ventilation maybe for the whole night, unless that place would be available in the ICU. So we've done the operation. It was the epidural bleeding, and the usual epidural bleeding after surgery would recover in a few days. So I've done the operations, and then we spent the whole night, me and 2 other nurses, doing manual ventilation for this boy, which is really, is very hard to, maintain, the O2 and the CO2 levels using only manual ventilation. But we were successful until the morning. A place became available in the ICU, and we've put this boy, and the boy recovered in 2-3 days. And then he was discharged a few days later. And a month later, I think a month or 2 months later, they visited the hospital again. And I was really busy doing other things in the outpatient clinic. And he was trying to, remind me with himself, like, I'm Ahmed, the boy that you've done a surgery to him. And when I've seen him, like, he was kind of a normal boy after 1-2 months. It was, you cannot imagine how you can feel when, yes, you saved the life of this boy, and this boy might be like, you never know what he will be in the future. He will be kind of a rebuilder of this country, hopefully. So these kind of moments would encourage you to do whatever you can to help more people, and then to forget all other challenges and your fatigue and other things you might face in this career.
Wow, Dr. Karim Ekzayez, thank you very much for coming on the podcast, and what an amazing story there at the end as well. It's been fascinating hearing about your work, your humanitarian work within Syria, and also your work with Save the Children, but now more recently, your research interests with King's College London. I wish you all the best in your PhD, and thank you so much again for coming on the podcast.
And thank you very much for the invitation, and good luck.
Thank you again for listening. If you enjoyed the podcast and want to hear more from us, please consider subscribing through your podcast provider. You can also follow Geeky Medics on Instagram, Twitter, and Facebook. We'd love to hear from you with suggestions on who you would like to hear from next. Thank you to the producers of this episode of the podcast, Alice Appleton, Abby Carter, and Dr. Lewis